We are good to go. Rita, the floor is yours.
Good morning. I would like to introduce Dr. Cameron Wolf. He's been my physician for about 11 years. And so I'm proud to say that I am so glad that he's with us. Dr. Cameron Wolf came to us COVID, and we had a very good discussion. So now he's going to come and update us on COVID-19 and to tell us what's going on with the vaccines. So Dr. Wolf, I'm turning it over to you.
Rita, thank you. Someone just give me a quick heads up once they can see my slides on the screen here. Yeah, okay. Well, hey, I appreciate the chance to come and discuss things with you. I enjoyed our chat last year. You know, a lot's changed since then, and so I figured we'd plow right into talking a little bit about where the epidemic is at the moment, and then we can talk a little bit more about vaccines as we get into the meat of this. So this data is as of this week, and really what we're looking at here to start with is a heat map of all the different counties across the US that are still affected. And this has really ebbed and flowed quite a lot over the year, but I can tell you one of the things that we still see, at least here in the hospital, is a pretty substantial number of patients here at Duke who are coming in sick each day. And as you can see here, still a pandemic that sadly has been sort of dominated recently in the southeast of the country. You could interestingly overlap an HIV map on this and it would look pretty similar. What's taken place nationally in terms of sheer weight of illness is that we got what we feared, which was sort of third wave, quote unquote. You can see that little blip in the summertime when we thought things were getting busy, but really in reality, in terms of sheer burden of cases, things took off in sort of mid to late October and then through November and December. And yet more optimistically, I think you can see there in the latter half of January, things just starting to really tail off. And I think we've felt that here too. Some of that may be vaccine, which I'll talk about in a little bit. I think some of it may simply be we're probably moved away from all of the congregating that happened around Christmas and Thanksgiving and New Year. And so we're not bundling together, sort of co-infecting people as much. But you know, the stark reality here is almost 450,000 deaths, which I think you kind of forget about how awful that number is. I mean, you know, we had 3,000 deaths on 9/11. That is more than the entire Second World War for United States soldiers. Like, it's an offensive number. I don't know how else to describe that. And yet it's such a large number that I think we sort of become numb to it. But we're probably at a point where I bet you if I surveyed this group where, you know, almost everyone now knows someone either in their family or very close to them who's now died. And I think that's kind of a threshold that we reached somewhere in the last month or two, I reckon, where it's kind of been immediately impactful to everyone. Whereas I think during the summer, this was still sort of a foreign thing for lots of families. You know, North Carolina is pretty similar. We've kind of tracked along at a fairly similar tick to what's happening in the rest of the state, but the country. But you can also see that decline that's really started to take place in the last couple of weeks, and I hope this will obviously continue. So with that, one of the things that we talked a little bit about beforehand was to then sort of map out now our much clearer understanding of what COVID does. You know, when we spoke a few months ago, I think we were starting to learn some of this information, but I think we're much clearer now on what can happen. There really does seem to be sort of two, or maybe in a few people, a rare third phase of this illness. The first phase that most of us go through and never hit. Later phases is simply a viral phase. It feels like a bad flu, or in some young individuals, it can sail through without feeling like much at all. And that's the kind of time, whereas if you look down in the green, we typically either try and give antiviral medicines to folks recently admitted to the hospital, or in fact, just symptomatic management if you're at home. The challenge is that often about a week into someone's illness, there's this change from a viral illness to what is essentially an inflammatory, almost autoimmune response. Your effort to clear the virus is so abnormal on some level that you sort of attack your own lungs fundamentally, but actually attack many organ systems. And so really our treatments then also change. We go from simply using antivirals to in fact using steroids or heavy immunosuppression, in fact, to try and calm down people's abnormal inflammatory response. And some of that actually is now being trialed with some original medicines that were trialed as HIV treatments that have sort of come back into flavor because they turn out to be really good at sort of calming down that abnormal immune response, but lots of work still to go. Fortunately, the numbers of people who make it to need the level of the hospital is still proportionally very small compared to the total number of people admitted. And yet, obviously, for those in the hospital, it's those latter sort of two phases there, the pulmonary and severe phase, that are much more devastating. So let's talk about vaccination, because I think this is really what I want to get into the meat of this entire talk, really, because it's how we get our way out of this. So when we talk about vaccines, the first concept that I think is just really crucial for folks to understand is this idea of herd immunity. What does that mean? Like, how does this help? And so in this sort of pictorial, you can see a herd of, what's that, about 40 odd people, where the blue are people who are protected. They've got antibodies, either because they were previously infected or that they've been vaccinated. The light blue are folks who've never seen COVID or a vaccine before, and the pink are actually infected at the moment. And the idea is that those two pink people on the left have the vast majority of people around them who are at risk. They can be infected, and so quickly virus spreads through transmission circles in that sort of setting. However, what we can then say is when we get to a point when we can actually vaccinate more of the community, and so you turn more people to blue, you don't take away all of the infection. It doesn't stop the odd person still having a pink infected situation around them, but the number of people who they could then run into who are at risk falls down. So you can see here in the picture that one little pink person who's infectious in the middle can still contact maybe one person, but the rate of transmission suddenly cuts out, and most virus dies with the person who it infects. Now, every virus has a different proportion of the community that we need to protect or vaccinate in order for it to die out. And we think with COVID, that's in the order of about 70%. To put that in comparison, to beat down a measles outbreak, we need it to sort of be around 90%. It's much more infectious. To beat down something like Ebola, it actually can be much less. But here we're looking at about 70% to get a pandemic under control. So one of the things that we do is that either has to come through natural infection, because natural COVID infection does give you some decent immunity for a period of time, probably some good months, or you've got to get it through vaccine. And so let's go back to that 450,000 deaths that we had on the front page. That is the cost of getting us to about 25% of our country infected. So you can imagine what it would cost us in terms of a death burden if we had to get to a full herd immunity through natural infection alone. This would burn on for years and we'd be in the millions. So vaccines, really do become our way out of this. There's no question around that. And we're doing better. We're up to consistently doing more than 1 million doses a day, which is nothing to sort of be dismissive of. That's a huge effort. But when you project what it would take for us to then get to 70%, if we stick to 1 million a day, we're still looking at this taking us the vast majority of 2021, unless we can ramp that up faster. So 1 million a day is good. It's nowhere near where we need to be. So I want to talk a little bit about the two vaccines that are currently available, and without diving sort of heavily into the weeds of immunology, I thought it's a fair basis to give you a little bit of background on them. So these are both novel vaccines in the way that they're designed, but it's not novel technology. This technology's been around for the better part of a decade. And in fact, other respiratory viruses were planned to be developed in this way, and then COVID came along and kind of redirected everything. But what these are, they're called mRNA vaccines. And so what we've known for a long time that the part of the COVID virus that enables it to bind to us so efficiently is a little surface protein called spike. What spike does is it binds to our cells and allows it to be drawn inside. So if you can block spike, you block virus getting into your cells. So what these vaccines do is, rather than giving us virus or giving us spike, they give us the recipe so that we make our own spike briefly. And our body then recognizes that as being foreign and produces an antibody response. We put that little recipe, that mRNA sequence, it's a genetic sequence that our body uses to create that protein. We put it in a little lipid sphere, and that lipid sphere enables your body to carry it into cells where it can be replicated. And then our own cells simply produce enough of it that our body recognizes it being foreign and mounts our defense. But the key is that I think the first myth that we often hear about people when they think about these vaccines is they go, hang on, like, you're injecting me with the genetic code of a virus? Like, how is that safe? Won't that alter my genetic code? And we're not giving virus particles here that can be incorporated into our long-term genetics. All that we're giving is the recipe, and the recipe, mRNA, typically gets broken down in about a day or two. That's what our body does with all of our own mRNA. So there's no persistence of that recipe. It's enough for us to make some spike, respond to it, and then it gets broken down and taken away. So actually, it's quite a purified and simple sort of design for a vaccine, but it is the first one that we brought to market using this sort of pathway. And to give you a little bit of a sense of how it then compares with other vaccines. So these are both 2-dose vaccines, the ones that are on the market at the moment. And from an effectiveness point of view, they hit it out of the ballpark. So this slide's a tiny bit old. So in fact, the Pfizer one turned out to be 95% as well when they got all their data in. So 95% effectiveness means if I took 100 people who were guaranteed of getting COVID, 95 of them do not. That's profoundly better than where we were shooting for. The FDA would have said, if you can get above 50 to 60%, we'll think that's enough, because that's what our flu vaccines typically get to. So to protect to 90 to 95 was just very, very impressive. There's some catches to these vaccines though. That little lipid bubble or nanosphere that it's called actually takes ultra cold freezing to keep it stable. So these vaccines are not ones that you'll find just in your regular pharmacy or on the shelf at the Walgreens. They need to be stored at sort of -20 or -75 to remain stable. And so that's the big difference for us so far, is that's a challenge to know who even has those kind of freezers, which is why you see so far universities focusing on having these in some health departments, but it's pretty limited so far in how we get them available. But when you look at actual performance data, like when I said these knock them out of the park, like this was really impressive to us. So it's impressive for two reasons. It's impressive, number one, because 95% protection is great. But number two, despite being marginally slightly different recipes using the same technology, they came up with essentially the same answer. So both vaccines kind of co-validated each other's approach because they essentially resulted the same way. So when you look on the left and you look at the red line, which is in the trial, the people who took the active vaccine, and the blue line, those who took the placebo, you can see that on the inset that those lines start to separate really pretty dramatically at about day 10 or 12. So it's fairly quickly after you've had the first dose that in fact you make a really prompt response. And then that second dose that follows up is what's felt to give us the longevity of how long it lasts for. But you can see sort of very, that's a flat red line, or the one on the Moderna is the same. Whereas the people who get the placebo, they kept on getting COVID. A really dramatic difference. So they're not without their side effects. And this is something that I think people need to be real clear on. So you can sort of think of these side effects as pretty similar, I suspect, all told. But having gone through this myself, so I got the active vaccine, I found out, as part of the phase 3 trial. My second dose was pretty noticeable. First dose felt like a sore shoulder. Second dose, I woke up with a fever and a headache and some muscle aches. And I don't typically respond to vaccines significantly, but I think it speaks to how positively stimulatory it is to your immune system that second dose triggers, quite a prompt memory response. Now, fevers and joint aches and temperatures are certainly not seen in the majority of people. In fact, most of us, when we get our vaccine, won't have these symptoms. Tends to be the younger you are, you're slightly more likely to get some side effects after the second dose. But the other big key is that these are all gone within 24 hours mostly. it's very, very rare for people to get these side effects lingering more than a day. So if you're someone who gets your second dose of the vaccine, you do feel some side effects in the hours or day afterwards. One of the big questions we get is, well, hang on, what's COVID versus what's the vaccine? Because these are pretty similar symptoms. The way we try and differentiate it here is if they last more than 24 to 48 hours, you probably should get a COVID test. And if you get something that's very COVID specific, like breathlessness, loss of smell, loss of taste, that probably warrants a COVID test too. But otherwise, don't be surprised if the second dose gives you some symptoms, because it's pretty common. But they're short and they're usually mild enough that they go away. And if folks want to use Tylenol or some ibuprofen or something for these, that's completely acceptable. We don't usually preemptively give those, but we certainly can if you feel symptomatic. I think one of the other things that was different here that's worth really honing in on is, traditionally at least, we've done a pretty lousy job in research, and vaccine research in particular, at looking at diverse populations. And yet there was a concerted effort here to really try and get an enrollment that matched closely, although I don't think anyone would say this is ideal, but at least closely mirrored the kind of populations that we see in the United States. And so what you see here is you see on both trials about 40% of folks who are non-white. And that's not perfect, but it's a downside better than what's happened in previous trials. The second point that's important here, though, is that not just were people enrolled from a variety of age and gender and ethnic backgrounds, but their efficacy and safety profiles were the same. And I think that's something that we've not done a good job on traditionally in the past, is say, does your HIV medicine, if you're a woman or a man, work the same way? Does the vaccine response, if you're African American or Asian, work the same way? Well, here we actually have data in these two vaccines that says, yeah, it's actually the same outcome no matter who you are. And that's important because I think when you then start thinking about who COVID has impacted the most, it's not white folk for the most part. It's been disproportionately impacting communities of color and communities where our Latino brothers have been. So it's important that we study these groups in groups that have been sort of impacted the hardest. And I think that's been much better here. As I said, not perfect, but a downside better than previously. So there are a bunch of other vaccines that are pending approval, and we would expect to move into the US market as well. One from AstraZeneca, which is now available outside of the United States. One recently given some data last week from a company called Johnson & Johnson and Janssen, and then one from a US company called Novavax. And we would expect that at least the J&J one goes to the FDA probably later this week or next week. And Novavax, I think, shortly after that. So fairly quickly, we'll see, I think, a bigger improvement in the number of vaccines available and therefore the number of patients who we can call up to get their dose. And some of these are a little different. So for example, that Johnson & Johnson one is a single dose. So you can imagine the appeal and the efficiency of giving a single dose vaccine to folks is pretty good. They have subtle differences in the way that they work, which I won't go into, but I think at the end of the day, all of them good vaccines, and all of them would have well and truly passed our sort of bar that we set at this time a year ago. There are plenty of things we don't know, and I think you've got to put them front and center here to make sure people are clear. This has been done quickly with really good reasons to do that. We were in a pandemic. When you get 3,000 to 4,000 people dying every day, these results need to come forward. But what I want people to know is that just because it's done fast does not mean that that was less safety monitoring or less people going through those trials. In fact, quite the opposite. So there were 73,000 people if you combine the Pfizer and Mrna trials that were put together, which is actually sort of 7 to 10-fold more than what we would typically get for a clinical trial like this. And part of that is simply because companies weren't doing anything else. They usually have 10 different irons in the fire. Last year, all they could do was research COVID. And us as patients, what else were we going to do last year except get into COVID research? So in fact, there was much more opportunity for these trials to get to their result quicker because we were in a pandemic. And similarly, from our sort of federal oversight point of view, I know trust in government particularly last year, was sort of shredded in many regards, but this was actually one area where they did a pretty good job at investing in factory development, in production efforts, even before we knew the result. So that was a bet placed on behalf of all of us as taxpayers to say, we need to have these vaccines ready to go. We can't prove that they work and then have no factory built ready to develop them. So that sort of investment, I think, helps us get to quicker results. Now, there's vaccine hesitancy in every community. How much it will impact us on COVID doses, I think, remains to be seen. We've seen differences already play out across ethnic divides, and sort of play out in ways across different states and across different political affiliations. You know, it probably surprises no one here that if you're right or left wing, you have a different opinion on whether you should go and get a vaccine, which is pretty sad, but that's the way it's going to pan out. We're going to deal with that. There were not people incorporated in these trials who were immunosuppressed, who were pregnant, who were breastfeeding, and who were under 16. And so how we then fold these vaccines into those groups then becomes a question that we've got to address. And so I'll move into that in a minute. So maybe the first little background though is, you know, having had all of this from an HIV specific point of view, what do we know differently about COVID? And what I can tell you honestly is that it's been the most reassuring things is that it has not had a huge impact on our HIV community disproportionately to folks with other comorbidities. And I think mainly that's because for the most part, we've improved our antiretroviral compliance, our T cell counts, and our immune system. So if you're sitting with a CD4 count of 50 or 100 or 150, yeah, COVID can be a more significant illness for you for sure. But if you're someone who's been compliant with your medications and for the most part you maintain good viral control, actually the outcomes of COVID are no worse in our HIV population. What can make that more complicated to tease apart though is that we do know that HIV is associated with high blood pressure, with kidney disease, sometimes with obesity or smoking history, and those sorts of other things have COVID risks for sure. But actually it's not so much the HIV itself. But this was a little list that was put together by the CDC of things that people should have at least thought about, and I think it's pretty valuable. Trying to maintain that you've got at least some active scripts, because if you can't get in or communicate with your physician to reactivate them, what are you going to do? You know, particularly as many of our clinics have not yet fully reopened at the same pace that we were doing, say, a year ago. Are you up to date on other vaccines, particularly flu and pneumonia vaccines, which can complicate a severe case of COVID? And then I think the bottom three things here is how do we even communicate with our physicians? So many of you who, and certainly those connected to Duke, would now have electronic medical record access. But if you don't, can that be a way for you to communicate with your provider teams in a way that makes it easier for them to like give you information and ask questions that maybe you don't then need to be in a crowded waiting room in order to figure that out? And similarly, you know, many of us in the HIV realm got into habits in the past through good reason to see everyone every 3 to 6 months. You know, maybe that's not as important anymore. Maybe if you're someone who's doing really well, you can afford to continue to social distance or do a telemedicine visit. And so to sort of figure out ways of connecting in that regard, I think is key. It's even more important when we think about vaccines, because sometimes the way big healthcare systems, and we at Duke will be the same, identify our patients who are next in line to get a COVID vaccine will be through our medical record. So it may well, in fact, be easier for us to positively identify you if you're a part of our system, and we know that that's you know, something we're going to do. So I want to talk briefly on sort of how we prioritize who goes first. One of the things here that was very important is if we know we get a need to get 70% of the entire country vaccinated, but there's obviously certain people who are higher risk, how do you split them up? And so this is the way that things are rolling out at the moment in North Carolina. So healthcare workers, particularly those in front of COVID patients, are on the top of the list, right beside nursing home residents and caregivers, because they're the people who've had the highest mortality. We've moved into the blue zone here, which is anyone over the age of 65, irrespective of how healthy or unhealthy you may be. And then as we move into phase 3, it's when we get into a large swath of people who have jobs that are deemed not only essential, they have to be there, but part of their job involves them being around inevitably being around other people, like the jobs that you can't do from home. So for example, it's postal workers, teachers, lawyers who work in the courts, prison guards, fire brigades. You can think of many things that are counted as essential workers, where the performance of that job puts them in front of other people. Group 4 is where most of our adults who may be able to stay at home, may be able to mitigate to a good extent, but probably have other risk factors that put them at higher risk will be, and then group 5 is essentially everyone else as well. So I want to get into a few myths. Number 1, single biggest comment to me, can this give me COVID? Absolutely not. So there is nothing in the current vaccines that are available or becoming available that is a living virus, particularly not living COVID. So while some people can still feel symptomatic from symptoms that feel like COVID after the vaccine, it's nothing to do with actual COVID. You can't pass that to anyone else. However, remember those graphs that looked at the split in effectiveness? It takes about 10 to 12 days. So if you get sick with symptoms that feel like COVID 5 days into your illness, yeah, that could be COVID, because you may not have had enough time sufficient for that vaccine to actually have worked yet. And there are 5% of people for whom it doesn't work. So you won't get it from the vaccine, not to say that you shouldn't still be thinking about COVID as we move forward. Secondly, all sorts of questions about pregnancy. And what's worth saying is that even though there were no pregnant women who were enrolled in the trial, there were some people who became pregnant during our trials for these vaccines, and they have not had complications, nor, according to our obstetrician colleagues here at Duke, some of whom sit on the FDA and the national bodies of the obstetric college, nor is there any real plausible reason to think that that could be the case, recognizing how they work. And so when you then balance that against the recognition that pregnant women in fact have more complications due to COVID, then I think this becomes a clear sell for us to in fact push this to pregnant women as a defense. Excuse me. The same is true for breastfeeding. The same is true for fertility. A lot of urban myths, frankly, about human cell lines and embryonic cell development in the use of these vaccines, and that is just factually incorrect. They do not need those products. They do not need cells to develop the 2 vaccines currently on the market in the US. There is some basis to that myth, though, because some of the overseas vaccines that are being developed do use historical cell lines where original fetal cells from sort of 30, 40 years ago are still used. They're not sort of used in fresh is the wrong word. They're not used in sort of new cells, but they have been originally developed from old cell lines, but they are nothing to do with the ones that are here in the United States. So if that is something that would be an issue for you, you don't have to be afraid of it, the ones that we have here. And like I said, there's no fertility concerns nor any reason to think that that could ever be the case, but that was certainly an urban myth that's been sort of spread far and wide. Some people talk about, if I don't get a response or if I get a side effect on the first dose, sorry, can I skip the second? And generally we would advise no, because it's the second dose that gives you the length of protection. And there are some folk who still get a really unusual anaphylactic response. And so that hit the press quite a bit early on. We've now had enough data, because we've given 25 million of these things out, to recognize that that risk is actually less than 1 in 100,000. So unless you're someone who carries an EpiPen, really you can come forward here with good confidence that these will be safe for you. And even the EpiPen, we then talk through and think about what's the actual risk. Some other vaccines in the past have been troublesome with neurologic complications, either Bell's palsy or a condition called Guillain-Barré, which is a pretty rare neurologic condition. There have been no cases reported of Guillain-Barré with these vaccines so far out of 25 million doses. So I think if it was going to happen by this point, we would have seen it. And the Bell's palsy situation can occur, but it's worth remembering that that's when the facial muscles of one side of the face lose their nerves transiently. What's important is that happens naturally in the back of the community anyway. So if we're going to give out 25 million doses to people, there's going to be a few who coincidentally develop a Bell's palsy through no fault of the vaccine. And yet we need to be able to separate those out and understand that it's probably not an actual vaccine effect. Final thing is that there's a lot of chatter about what are called variants or mutations. And sort of we in this community are probably a little more familiar with discussions about mutations because it's something we're used to talking about. The general community is perhaps not so much. But this is what viruses do. If you have a ton of cases of active COVID flying around, those COVID will be slowly mutating. And some of those mutations will actually allow the virus to become a little more fit, a little more transmissible. And so that has occurred at least a few significant times, one in the UK, one in South Africa, and a different one in Brazil. A lot of chatter that you'll read about whether that makes the vaccines ineffective or less effective. Will the disease be more significant? And in fact, I think what this is that this is a call for us to vaccinate more aggressively. Because just in the same way, if someone takes their antiviral meds effectively, they're less likely to get a mutation than if someone who's got a viral load of HIV of 100,000. In the same way, if we can drive down the community amount of COVID, there's less virus to mutate, and it actually becomes much less common that these things cause problems. And I want to end with this little slide because this, I think, is the most crucial. No matter all the data that you hear about vaccines, this summarizes beautifully the take-home message. Like there's about 60,000, 70,000 doses there from different trials. Hospitalized for COVID if you got the vaccine, 0. Hospitalized for COVID who died of COVID, 0. And hospital died because of the vaccine, 0 in the trials. So that's profoundly impactful. Can people still get some COVID after the vaccine? Yeah, sure. But the take home here is that it's going to be mild. And so, you know, boy, you want something to end on that should hopefully convince most of us that this is the right thing, then that slide, I think, speaks to me in that way. So on that line, I'm gonna pause, and I think we can just go open slather with questions. I'm happy to answer anything anyone wants. So I'll stop sharing, Rita, and pass back to you if you want.
Thank you for that. That was a very good talk and very informative. Does anyone have any questions? Thomas, I know that you put one in the chat, but does anyone else have any questions at this point?
Well, I can tackle Thomas's first because I think it's a good one. So people living with HIV will fall under that category 4 when we looked at the sort of the timelines of when it gets rolled out. And even though that was North Carolina's timeline, it's basically true for most other states. It's counted as a comorbidity that puts people at marginally higher risk of COVID. Although, like I said, I think someone's greater concern ought to be their age, how well their diabetes is controlled, obesity, hypertension, these things. If you've got well-controlled HIV, I'm less concerned for your health. Not to say you shouldn't get a vaccine. And so the way we plan to do that is as we move into our third and fourth phase, you know, we at least have the ability now with all of our medical records electronic to sift through and find folks who have certain comorbid illnesses. And, you know, HIV will pop up on most people's tests there. And so we would then be emailing those folks or notifying them publicly to say, right, you know, now it's your turn. Here's a number or an electronic way of creating a vaccine appointment. Come on in. That's dependent not only on us being able to find people in our records, which is why I put a call out early on for folks to be keen to activate their electronic medical record. If you're in the Duke system, that's the MyChart account. If you're in a different medical record system, I'll bet most these days have an ability for you to communicate with your clinic through that, because that'll be the way that for the first part, it's the easiest for us to communicate back to you. The other thing that it's really crucially dependent on, it's dependent on our vaccine supply. So right now, we have more people lined up ready to give vaccines and more people lined up ready to receive vaccines than we have doses. So unfortunately, I can't sit here yet and really say, Thomas, your turn is going to be on March the 23rd, because we don't know week from week from the state what our supply will be. And they don't know week to week from the federal government what the supply is going to be. So it does make planning for these sorts of things actually pretty complicated. I can tell you where in the pecking order you'll be, but it's a bit less clear to me as to when we'll actually get there. I hope that makes sense. And to be fair, like if you get a first offer that comes from the county health department, you should grab it. Or if you know that the county next door has a vaccine event, there's no reason we're very clear that folks can cross counties and get vaccine doses. No issues with that at all either. The only one thing that we'd caution people on is if you get a Pfizer dose the first time, you should get a Pfizer dose the second. If you get a Moderna first and Moderna second, we don't know what the crossover would do, so we don't recommend that.
Dr. Wolf, I have a question. This is Christina.
Hey, Christina.
So let's say you were mentioning how there were folks who were hesitant about the vaccine and are unsure about taking it.
Yeah.
If too many folks are in that category and end up not getting the vaccine, how is that going to impact the rest of us? I know you were covering it a little bit earlier, but I'm just thinking, if like we were to get vaccinated, but then a lot of other folks didn't, how quickly can we go back to normal? Is that even possible? Are people going to be more infectious or not? I'm very curious about that.
Yep. And you are asking the absolutely most poignant question, because I think that your point is well taken. Unlike many other vaccines where I'm only vaccinating myself to save myself, like shingles, for example, here I'm vaccinating every one of you all to help all of us. There is a community effort here that is absolutely crucial. We are all in this same swimming pool trying not to drown. And there's no way of vaccinating half of the population without the other half still posing us a lot of risk. The fastest way to get out of this from when can we go back to normal, quote unquote, is that we treat all of us the same way and vaccinate all of us. Because I think you can't expect a virus to go away if you only get 40 to 50% of your community covered. It'll keep transmitting, and we'll still have people in the hospital, and governments and response agencies will still feel obligated to make us wear masks and restrict activities, and things won't feel normal. And economically, we've seen what that does from an impact point of view. So, if you look at some of the countries and areas that have done well, they have viewed the entire country or community as equally relevant to vaccinate and protect. And your point is spot on. I can vaccinate you and that will help you, but until I can vaccinate all the people around you, there will still be COVID spreading in your community. And eventually what happens is, like we're talking about mutations, if I keep getting if I keep getting virus spreading at a decent level, sooner or later complications happen to that, and you either develop mutations that put you at risk again, or we continue to stay in this sort of restricted quagmire that we're in at the moment. So, last year there was lots of sort of, maybe it was the election or maybe it's just general politics, I don't know, that sort of lots of comments about, well, hang on, I don't need a vaccine. I'm 25 and healthy. I don't need a vaccine because I've already been infected, or I don't need a vaccine because I think natural immunity is going to be better. And I'm really sad in hindsight that those sort of discussions dominated our national discourse, because to concede that point and to give up that you need a vaccine accepts that you're kind of happy that as a community we race towards 1 million deaths. Like, it's awful. There's no way around that. I have to get every single person here vaccinated if I can, in order for all of us to go back to some sort of sense of normality.
So do you see that the government may require folks to get the vaccine, like other vaccines that we have to take to go to school or to travel certain places? Do you see the COVID vaccine being something like that?
Yeah, that's a real hot potato. It's not yet. There's no federal mandate for that, nor I think appetite to do that. That's different already overseas, and it would not surprise me if in the next year or two, I think we move in that direction. So there's already some businesses that have hinted that they will move in that direction for the safety of their workers and their own business continuity. There are certainly schools that have hinted at that, which I think would not be inappropriate for the safety of their kids or their teachers. My national airlines for Australia has come out very clearly and said, if you want to fly from the United States, we're not going to let you on the plane unless you've had a vaccine. And I don't think that's an unreasonable effort. Like, why would I want to sit next to someone on a giant tin can for 18 hours flying over the ocean if they weren't protected? So, but in answer to your question, that there's no mandate yet. And I think at the moment it doesn't make sense because I don't have a vaccine supply that's strong enough for a mandate to have any teeth. Does that answer your question? I think it would be helpful, but I don't think we're in a position to do it.
Yeah, I do. Yeah, I agree. But I do think that corporate interests are gonna kind of guide that conversation. And I do think it's eventually gonna happen effectively. It may not be like a mandate like you were saying, but I can definitely see airlines, schools saying like, you have to be vaccinated to, participate.
Yeah, I mean, the way we do it in a hospital is if you work in Duke, we've said we don't, what's our mission here? Our mission is to maintain the health and improve the health of our community. And therefore, if you want to adhere to that mission, I don't want you as a healthcare worker to bring flu into our community, into our hospital. And so we put in a mandate for flu vaccines now 7 or 8 years ago, and it dragged our flu vaccine rates up from sort of 30, 40% to 98%. And our community gets less flu as a result. And so, I think that makes sense, not just from I don't know that it's necessarily a business question. I just think it's medically the right thing to do. Although people will see it also as a business situation as well, which is probably true.
I agree.
So along the lines of, I know we talked about there being a limited supply, and that's kind of one of the things that's really holding back the distribution of the vaccine. Do we have an idea of how long it takes to actually create it from start to finish, to increase? I know patents and all of that kind of limit stuff, but how long does it take for the actual dose of vaccine to be created?
Yeah, I mean, I think you're assuming that all the trials have finished, and if I now pump your company with $100 million and say, go and make me more doses, what does it take? Realistically, there's no way of turning that spigot on within the space of a couple of months, because what needs to happen is you're assuming you can quickly get factories and machineries online. You're assuming that you can produce vaccine that gets quality checked to make sure that, what you're producing is what you say you're doing and there's no variability and variation in that. And you're making enough of it to then distribute it to various parts of the country or the world. Let's be honest, this is not just a US issue, clearly, this is a global issue. And so, realistically, money is not the limiting factor there. It's many logistic production questions and distribution issues. And so I don't think, for the Biden administration, for example, when they say we're going to lean on companies to make more, there's limited pace that they can do that with. They can't bring, it's February the 3rd. You can't tell a company to go and make more and expect it'll be here anywhere in February. But that's part of the reason why appropriate investment last year was investing in companies' production capacity and distribution capacity, such that when we were now able to prove that these vaccines work, that we've already pre-purchased them. We've already invested in a number of factories ready to go. They've already started making some of them before they even knew that they were going to work, in order to guarantee that that supply would just start moving as quick as possible. And the risk, of course, is that you build a factory and make a ton of vaccines that don't work, you've got to toss them out. That's happened with a couple of companies, but that was an investment sort of decision that we thought was worthwhile, and I think it was a good choice.
Dr. Wolf, can you touch quickly on the strand of it and how that affects an individual in how the vaccine works on the individual that has the second strand?
You cut out for a tiny bit there, Rita. I think you were talking about the variations of COVID, the mutations that we've seen. Yeah. So there's first thing to say is that all of those variants that we hear about are probably here. US have not nationally done a great job of sort of surveying the landscape to see how common they are yet. So, but we should expect that they're here. And what is shown is very clearly that when I give someone a vaccine, I make lots and lots of different antibodies to that little piece of spike protein. And so even many of the mutations that occur, you've still made sufficient antibodies that even if you contracted that virus, it'll be far less severe. So I think people shouldn't be afraid of those mutations as a reason not to get a vaccine. Like I said earlier, it's in fact a call to get some protection up and running as quick as possible. This is kind of like protease inhibitors for HIV. It takes multiple hits for a virus to mutate sufficiently that your antibody response to a vaccine would not work at all. Far from it. I mean, if I take good faith as a person who's had both doses that my chance of getting a meaningful infection from any of the current variants is nigh on zero. So, but that doesn't mean that we shouldn't be looking out for that. It doesn't mean that there's not the potential for mutation to occur that can be more significant or evade the vaccine. And if you ask me that question in 3 or 4 years, we may be in a situation when we've found out more about how long these last for, that we find we have to tweak the vaccine every couple of years subtly, like we do with the flu vaccine. That would not at all surprise me if that's what we have to do as we adjust to different strains that appear and readjust the vaccine accordingly. That would be my expectation, in fact, of what happens.
Has there been any trials that have tested for transgender communities that take hormones, and whether that has an effect on the medication or not?
That's a good question. So I don't know that hormonal use or in fact any part of the LGBT community would have been excluded from the trials. There's no reason why they would have been. We did exclude HIV patients from the trials because part of those trials were designed to measure immune response for the general community. And it is true that once you've been HIV positive for some period of time, your immune response is different to vaccines. So they didn't want to muddy the water of the trial result. They needed answers as quickly as possible. That would not have excluded anyone from an LGBT community or transgendered or on hormones for that matter. So whilst I can't tell you how many people would have been in those trials, I don't know of a biologically plausible reason why it would make a difference. And I guess the other thing that to me gives me comfort in saying that is that there was no gender difference in people who identified as male or female. The effectiveness and safety was the same. And so I remember actually from the trial, it didn't ask me what was my gender at birth. It's asked me, do you identify as male or female or other or unknown, or I don't want to say, I can't remember exactly the question, but it didn't matter. And I don't think it matters from the vaccine point of view. I can't see any reason why it would.
Does anyone else have any questions?
Yeah, this is Hunter. So you spoke about the mRNA vaccine and tagging on your last question. Since the HIV population was excluded, are there any reasons that people should wait on, say, the J&J vaccine instead of, who are on antiretrovirals, instead of doing an mRNA vaccine? If that comes out at that time, just move toward that because it's been so unstudied and might have a different immune response or not have the immune response that you want.
Yeah, no, it's a good question. I would actually go the other way, I'll be honest. I think the data that we have so far is more supportive of the mRNA vaccines potentially than some of the other ones in terms of effectiveness. And so these are all new when it comes to new vaccines. So even the J&J one, for example, that uses a viral vector. It uses an inactivated virus to carry, gene sequences in, and the same with AstraZeneca and the Russian Sputnik vaccine, and plenty of others use attenuated viruses. They're all different. They're all new. None of those were around this time a year ago. So we don't know whether one is better than the other, put frankly. And so I think what you should do is you should look at their overall effectiveness. You should look at their overall safety to prevent severe illness, which is great across the board. And I think you should most importantly look at what's available. And I think if your first availability is a J&J dose, I would absolutely recommend it. But if the first call that you get is one of the Pfizer or Moderna vaccines, I would have no hesitation in recommending them. And I think the lack of clarity, because HIV patients were not involved in those trials, to me is twofold. Number one, it's, do you mount the same response as someone who is HIV negative? And I would posit to you that if your T cell count is well controlled, you really should. There's no reason why that would be different. Or is the durability, how long it lasts, different? And so this same question comes up for people who are on chemo. Same question comes up for people, my patients who get transplanted for a kidney, for example. We're not clear as to how much that diminishes the response or shortens the response. But it's very clear to me that they still should get vaccinated, because if they get more side effects, even if I give them a 50% efficacy, that's better than doing nothing. So I would get the first one that becomes available, and if I had a choice, I wouldn't necessarily be afraid either way. And whilst they're new vaccines in the sense that we haven't had an mRNA vaccine before, I think now 25 million doses in and, very robust safety data out of the trials, I don't know a biologically plausible reason why they'd cause us problems at this point. Now, some people prefer just one jab rather than two, and if that's the case, then yeah, go for the J&J. But I don't think it's a big difference otherwise.
I have a question.
Yeah,
Hi,
please.
Dr. Wolf, thank you so much. So there's, and I don't know if this was covered because I was in another meeting. I got on late. I apologize. But is there a difference with the vaccine according to when we're talking about shelf life, and how good, if any one or the other, is good with children? Because that's the one area that we left out is children. And I'm just wondering your perspective, or would you say the same thing, both these vaccines would be good for them?
Yeah, they're two really important questions. I'll concede I don't know shelf life for the vaccines. That's a huge question. I don't know. I will say that the storage for both the Moderna, but particularly the Pfizer vaccine, is complicated by how cold they need to be stored. So when you think about the distribution of these vaccines on a global level, it's complicated to send something internationally. Let's say you wanted to send shipments to Kenya. Like, how are you going to do that when you need minus 80-degree freezers and they're not readily available? So I think there's complexities to the distribution, but I don't know the answer for shelf life. It's a great question. I should learn that. In terms of kids, they were kept out of the original trials for one main reason. Well, two really. Traditionally, we like to prove vaccines in adults first and then move into the pediatric realm. That's true for any trial. But I think here that was particularly important because kids, for the most part, have not had severe illness due to COVID. Almost universally, they do not. Whereas we knew this was a bigger impact for adults, and particularly older adults. So there was actually a focus to target, in fact, more the other way and try and enroll heavily in patients over the age of 65, which is often an ignored group in vaccine trials. So that has left us in a situation where Pfizer is approved from 16 and above, Moderna from 18 and above, and that none of these are at the moment approved in children. So the best way to manage your teacher or your parents is to get them vaccinated first. Now, the trial that studied the Pfizer vaccine in people from 12 to 15 has completed, and we're waiting to hear their results. The trial is about to open for children between 9 to 12, or 8 to 12, I think, and that will give us more information. So by that stage, you'll know pretty much that these ought to be effective in sort of middle school and high school aged kids. But at the moment, that data is not available. I don't know. So we are solely targeting people over the age of 16. And I think that's okay, because I think for the most part, they're the people that get sick. Well, it is right on 12. So I appreciate plenty of good questions here. You're always an interactive group. I like it.
Awesome. Yeah. Well, thank you so much, Dr. Wolf, for this super informative discussion. We did record this, so we'll post on our YouTube for anybody who was not able to join us. If anybody has any additional questions, feel free to reach out to me or anybody on our team. We can hopefully get those over to Dr. Wolf and get those answered. We super appreciate it. And thank you all for joining us today. Have a wonderful rest of your Wednesday, and we will see you all soon.
Bye.
Thanks so much for hosting.
Bye, everyone.
Thank you, Dr. Wolf.
Thank